Hello and welcome to the 2021 Virtual CHW Summit. My name is Jacqueline McLeeland and I am the founder and executive director of Push Birth Partners, also known as PUSH. Before we begin, I would like to review some housekeeping items with you. This is a pre-recorded session, but the Q&A section of the Thinkific platform is being monitored to respond to any questions that you may have. You can access the discussion tab at the top right of your course player whenever you have a question to ask. The course player is where you're watching this video now. Just click on the image of the two alternating boxes, then click Create New Post to submit your question. Questions will only be answered on the day the presentation premieres. Today's slides and additional resources pertaining to this presentation are made available inside the Thinkific platform. You can find them by scrolling down past this video. As a reminder, we do ask everyone to complete a survey about this session. The survey is located inside the Thinkific platform. You will be prompted to complete the survey at the end of the presentation. If you do not receive a prompt, you can find the survey in the summit outline. Additionally, please complete the summit survey at the completion of this week. These are very important, and Lumumba Health uses every bit of feedback to help inform future educational events. Just a reminder, this presentation has been approved for continuing education hours for CHWs, CHW instructors, and certified health education specialists. In order to obtain your certificate, you must complete the summit evaluation by April 23rd, so don't miss your window. Today's presentation is titled Fostering a System of Support: The Impact of CHWs in Maternal Health. By the end of this presentation, you should walk away with more awareness regarding the status of maternal health in the United States. Understand how the qualities and core competencies of a CHW are fundamental to improving access to care and resources, and acknowledge some of the recommendations and best practices that we will cover. Recommendations, for example, by maternal mortality review committees, as well as best practices that have been implemented in other public health initiatives. Let's look at the definition of maternal health. The World Health Organization refers to maternal health as the health of a woman during pregnancy, childbirth, and the postnatal period. I think it's important to understand for organizations such as PUSH and for advocates such as myself, maternal health also includes the phase before a woman gets pregnant. Throughout this presentation, you will hear the terms morbidity and mortality. And before we go any further, I want to make sure everyone is clear on what is morbidity and what is mortality, because they are not the same. The technical definition of morbidity is the incidence of disease or the rate of illness, whereas the technical definition for mortality is the number lost or the rate of loss. In terms of maternal health, morbidity is any health condition attributed to or aggravated by pregnancy and childbirth that has a negative impact on the woman's well-being. Keep in mind that some definitions may include pre-existing conditions prior to pregnancy that are deemed contributing factors. For maternal health mortality, it's the annual number of female deaths from any cause related to or aggravated by pregnancy or its management during pregnancy and childbirth, or within 42 days of termination of pregnancy. That term or that phrase, termination of pregnancy, references any period in which that pregnant woman is no longer pregnant, whether she had a successful childbirth and delivery or an unsuccessful childbirth and delivery. It also includes in the event she suffered a miscarriage. How would you rate your maternal health IQ? Let's play a little game. I know that this is a pre-recorded presentation, so you can just play along and just make a mental note of your answers. There are only 3 questions, but let's just see how well you do. Number 1. Among 10 other developed countries, this country is the most dangerous to give birth. The answer is the United States. Think about that. The most dangerous country among 10 other developed countries to give birth, for a woman to have a child successfully, the United States. That is troubling. I was very surprised when I initially learned this a couple of years ago while reviewing maternal health data. I'm going to take a moment and read a statement by the Commonwealth Fund. In 2017, at a time when maternal mortality was declining worldwide, the World Health Organization reported that the U.S. was one of only 2 countries, the other being the Dominican Republic, to report a significant increase in its maternal mortality ratio since 2000. While the U.S. maternal deaths have leveled in recent years, the ratio is still higher than comparable countries. And of course, significant racial disparities remain. Number 2, the number of women who experience life-threatening postpartum complications annually. The answer, 500,000. Number 3, true or false? Most maternal deaths are not preventable. The answer, false. Over 60% of pregnancy-related deaths in the U.S. are preventable. So what defines preventable? We will discuss in just a moment. Here is a map of the United States. I wanted to give you all somewhat of a visual to understand the activities and what's happening within certain states throughout the nation with regard to maternal deaths. So this is a map that was shared by USA Today in 2018. They conducted an investigation for each state to see what the maternal death rate is within each state. And what you see here, like what appears to be lighter pink or darker pink or maroon, depending on what color you may see within those shades. The lighter states in pink indicate those are states that reported a lower maternal death rate compared to the states that are in a darker reddish, maroonish color. You will notice on the West Coast, for example, California and Nevada, those states are grayed out. They were reporting a much lower maternal death rate compared to these other states that you see in the red and maroon category. You notice Texas as well as Arkansas are kind of in the same shade of maroon, reporting much higher rates compared to states like New Mexico and Arizona. Then you look at Louisiana. You look at Louisiana and 3 states over you see Georgia, and you go further up and you see a darker maroon state, which I believe is Indiana. Those states are reporting a much higher rate compared to the other states in a lighter shade of maroon or pink. They are reporting higher rates of maternal death. So I wanted to share this to give everyone somewhat of a visual to understand some of what is happening within each state regarding maternal death. If you recall, previously I mentioned maternal mortality review committees towards the beginning of this presentation. So there are state-level initiatives made up of individuals and organizations whose purpose is to identify, review, and analyze maternal deaths. Such initiatives that are formed on systems level are commonly referred to as Maternal Mortality Review Committees, or MMRCs. These committees are typically made up of members who are in the areas listed here in the bullet points, from public health all the way to community-based organizations. Here on the left is a map in various shades of blue. This is a snapshot of states that have implemented system-level programs and changes to address maternal mortality as well as racial disparities. This is as of 2018 to 2019, and it's based on 4 criteria, and they vary based on the shades of blue. So for example, the states that appear more in very light blue or maybe even close to gray shade, those are states that have met all 4 criteria. So the criteria include states that have a maternal mortality review committee. They may also have implemented a perinatal quality collaborative. They have expanded Medicaid, and they also have some type of reporting for proper data reporting by race as well. Now, if you look at a state like Texas, which is not exactly, it falls like more in the middle shade of blue compared to, for example, Wyoming. Texas, for example, met most of the criteria out of the 4, with the exception of Medicaid expansion. So the shades here, that's what they recommend. And again, just a snapshot for you to get an idea as to what each state is doing as far as meeting certain criteria based on those 4 criteria of system level changes to address maternal health challenges and mortality and racial disparities. Over here to the right, this is another map of the United States, and this image here represents states that are part of the CDC ERASE program. ERASE stands for Enhancing Reviews and Surveillance to Eliminate Maternal Mortality. So that's the ERASE program. So certain organizations and agencies within these states receive funding. And the funding is for the purpose of reviewing and categorizing maternal deaths to identify prevention opportunities. Going back to the maternal health IQ assessment, I promised we would revisit the concept of preventable and what defines preventable outcomes in maternal health. In the previous slide, we discussed review committees, commonly referred to as MMRCs or Maternal Mortality Review Committees. Well, in Texas, we have a review committee. That review committee includes the term morbidity, and their committee is called the Texas Maternal Mortality and Morbidity Review Committee. So MMMRC, we have an extra M there. The Texas MMMRC was established in 2015. This review committee, along with the Department of State Health Services, or DSHS, they submit a joint report every 2 years. This report discloses findings and recommendations. The first biennial report was released in 2016, and the most recent report was released September 2020, so just a few months ago. In that report, they define preventable, which is pretty much consistent with other maternal mortality review committees across the nation. Preventable is defined as a death that had a chance to be avoided if there were reasonable changes to the circumstances, whether those circumstances were patient level, provider level, facility level, systems level, or any various community factors. Now that we have confirmed the review committee's definition of preventable causes, let's look at some underlying causes of maternal mortality as reported in the MMMRC's biennial report. Here we have cardiovascular and coronary conditions, which deals with the arteries surrounding the heart, as well as mental health disorder. These appeared most often in the records reviewed. The second most common causes include obstetric hemorrhage, which refers to excessive bleeding that can occur during pregnancy, childbirth, or in the postpartum phase. You also have preeclampsia that showed up, which is a potentially dangerous pregnancy complication characterized by high blood pressure, sometimes leading to damage to other organs within the body. You have infection and embolism, which is formation of blood clot that could lead to blocked arteries. Third most common causes according to the records reviewed, include cardiomyopathy as well as conditions involving the lungs. Now, these findings were consistent to leading underlying causes of death reported by the CDC. This would indicate that these results from the Texas MMMRC are consistent with other state reportings. The next couple of slides, including this one, I will not dive into the details, but this information is very relevant to understanding the need for health equity. I wanted to share this graph to help viewers visualize the variations in maternal health in respect to certain communities and the conditions impacting these communities. This graph represents causes of pregnancy-related deaths in the United States by race and ethnicity. The first column encompasses all of the populations to the right of it: white, Black, American Indian and Alaska Native, Asian Pacific Islander, and Hispanic populations. Here is another graph to give you a clearer picture of racial and ethnic disparities in pregnancy-related deaths. From 2007 to 2016, you see a consistent pattern of Black women along with American Indian and Alaskan Native women at much higher rates of pregnancy-related deaths. Think about that. Here we are in COVID-19. This pandemic has exacerbated this issue, and I am nervous to see in the aftermath of this pandemic what the data will reveal. This is why we are in dire need of a community initiative to address maternal health challenges. Here we have disparities by education level. The pregnancy-related mortality rate for Black women with at least a college degree was 5 times as high as white women with a similar education, meaning socioeconomic status, education, and other factors do not protect against disparities. Patient-level factors, community factors, and system factors such as sexism and racism are also drivers in racial disparities. Black women are 3 to 4 times more likely to die from childbirth than non-Hispanic white women. I urge you to take some time to process this along with the previous graphs, since this video will be accessible following the presentation. Pictured here is former First Lady Michelle Obama, along with her 2 daughters, Malia and Sasha, and her mother, Miss Robinson. Michelle Obama has spoken out about her own maternal health challenges with infertility. I absolutely love this quote about sharing the truth about our bodies. This not only helps to relieve the feeling of shame and embarrassment, but it builds awareness and allows us to learn, to grow, and also improve the various challenges in maternal health that have existed for far too long. Other high-profile personalities who have come out to share their own personal childbirth experience include Tatiana Ali, Serena Williams, Beyonce, and Allison Felix. They have brought attention to maternal health as well as the impact on certain communities. Tatiana Ali, for example, wrote in an essay to Essence magazine in 2019 sharing the chaos that happened in the delivery room prior to her son being born. This chaos led to an emergency C-section. She was quoted stating, "Yet U.S. media have pathologized the story as though Black women, Black families, and Black bodies are to blame. Some Black women I've spoken with are now scared to get pregnant as if something is broken in us. Because our lives are so often framed in a culture of poverty narrative, I fear that we have internalized the problem and made ourselves the cause when the truth is we are being treated unfairly, disrespectfully, at worst criminally, or not treated at all." Allison Felix testified on Capitol Hill in 2019 about racial disparities following her own life-threatening experience. She was quoted stating, "Mothers don't die from childbirth, right? Not in 2019. Not professional athletes, not at one of the best hospitals in the country. I thought maternal health was solely about fitness, resources, and care. If that was true, why was this happening to me? I was doing everything right. Serena Williams also has come out and shared her story and how she had to advocate for herself following the birth of her daughter Olympia. She was quoted stating, "When Black women in America or around the world have complications like mine, there are often no drugs, health facilities, or doctors to save them. If they don't want to give birth at home, they have to travel great distances at the height of pregnancy. Before they even bring a new life into this world, the cards are already stacked against them." And then you have Beyonce, who has disclosed that she developed preeclampsia during her pregnancy with her twins. She was quoted stating, "I have a connection to any parent who has been through such an experience." I'm going to read a quote from Glamour magazine, I believe was posted August 2020. "Inequality is rampant throughout the healthcare system. Women of color are more likely to die of breast cancer, heart disease, and COVID-19, and more likely to report chronic severe anxiety. There are many reasons why: gaps in biomedical research, deliberate discrimination and racism, lack of resources, lack of empathy, all of which come to a head when a Black woman gets pregnant." Again, this is a public health crisis that cannot be ignored. Why CHWs? Why community health workers? How do CHWs tie into all of this? Well, because CHWs exhibit what we often lack in today's healthcare system, in business, and in other areas of our society, and this is a growing concern. CHWs exhibit the power of human connection, the emphasis on being human. CHWs, in my opinion, embody the true essence of servant leadership, which leads me to the next point. What are the qualities and skill sets of CHWs? These 8 CHW core competencies are set forth by the Texas DSHS. These are also commonly identified as key elements of other CHW programs. The core competencies are universally applicable to the CHW workforce, as well as in establishing an effective CHW program, irrespective of geographical location. So let's go ahead and take a look at each of these skills and connect the dots on how relevant these competencies are in developing a community approach to help mitigate maternal mortality and morbidity. Communication skills. CHWs provide tailored support for the individuals, families, and communities that they advocate for. The training that they receive in effective communication equips them with the skills needed to help deliver patient-centered experience. Building trust within the communities and population of interest are part of their training, while helping to build confidence that will enhance the ability of individuals to advocate for themselves or on behalf of a family member. Some of the characteristics associated with communication skills in the training of CHWs include active listening, non-judgmental, respect, and being open-minded. Interpersonal skills. CHWs are encouraged to practice authentic self-awareness by having a clear understanding of themselves from their own perspective and the perspective of others and their interaction with others. Doing so will aid in continued development of positive behavior while making the necessary adjustments to the habits and behaviors that may be offensive or affect other people. Some of the characteristics associated with their interpersonal skills include empathy, authenticity, connection, and establishing boundaries. Service coordination skills. CHWs must be equipped with the tools necessary to better serve their community. In doing so, CHWs are continuously strengthening current relationships, creating new ones, and organizing therefore building an infrastructure of various support systems to improve care for the development and improvement of community service. Such tasks and responsibilities take careful planning and research in order to carry out effective initiatives and interventions while ensuring such services meet the needs of the people who benefit from them. Characteristics include research, partnership, planning, and observation. Capacity building skills. The ability and willingness to identify inequalities is vital to the role of CHW. Such attribute aids CHWs in recognizing where gaps exist. This allows CHWs to set goals necessary to address the challenges that are preventing individuals and families from meeting their needs. By including the community, CHWs help to foster a system of participation and collaboration, allowing individuals and entities to understand their role in leading social change, improving lives, and strengthening communities. Characteristics include engagements, a sense of community, transformation, and interdependence. Advocacy skills. CHWs are advocates who help to raise awareness, educate, and seek justice on a given issue through action for or with the population and communities they work within. They are constantly asking the question, why? To help get to the root cause of a situation and to provide solutions. Rather than enabling, CHW advocacy initiatives help to inform and empower communities to advocate and take action for themselves, affect policies, and encourage improvements for current and future generations. Characteristics include taking action, the art of storytelling, educating, and supporting. Teaching skills. Often what sets the role of a CHW apart is having a unique understanding and or connection to both the community they work with and the subject matter at hand. Cultural humility and responsiveness are advantageous to CHWs when determining how to adjust for or their teaching strategies to fit the needs of stakeholders. CHWs must also take into consideration factors such as setting goals and expectations, preparation and organization, delivery of material, as well as the learning environment. Characteristics include being a subject matter expert, but let's look at that for a moment. Being a subject matter expert doesn't mean you have all of the answers, but it's also the ability to recognize your strength and where you may need some adjustments. And if you don't have the answer in that moment, making an effort to find the answer. The ability to make connections, the ability to strategize, as well as having flexibility. Organizational skills. I think it's fair to say most would agree having strong organizational skills is very beneficial. CHWs understand the importance of organizational skills and the benefits of adopting healthy organizational habits. Such advantages include managing expectations, completing tasks, minimizing complications and errors. In any regulated setting, CHWs minimize the risks of non-compliance issues when consistently practicing good organizational skills. Some characteristics include structure, prioritization, self-management, as well as time management. And finally, knowledge-based skills. CHWs demonstrate experience and knowledge by having a thorough understanding of the community, the barriers, and social determinants. This awareness and understanding of health and social services systems and what is happening within the community allows CHWs to better plan and determine measures needed to improve health and access to care for individuals and families. Some characteristics include experience, a commitment to continued growth and education, for example, attending this virtual CHW summits. Cultural humility and awareness. The qualities and core competencies of CHWs are precisely why more programs could benefit from having CHWs as key members of an organization. Rigorous studies in recent years continue to demonstrate the benefits that CHWs have had on the healthcare system, including appropriate use of preventative and primary care. CHWs have been instrumental in the response to previous disease outbreaks and more recent, the current pandemic. A study conducted by Klein and Hostetter identified areas in which CHWs have contributed to improve health behavior and outcomes in maternal and child health. This infographic is a result of that study, which highlights areas that CHWs have had a positive impact on maternal and child health by encouraging women to pursue recommended maternal and child health care, by helping to increase children's vaccination rates, promoting screening for cancer and breast and cervical cancer, and promoting better nutrition. So according to Health and Human Services, hospitals and maternal service providers can utilize certain steps to begin taking action towards improved maternal health. These action items include data analysis, addressing social determinants, community engagement, building partnerships. Do these action items sound familiar? Because they should, considering all of these are just a few of the many skill sets of CHWs that were recently highlighted in the previous slides. Listed here are the recommendations by the Texas MMMRC from the September 2020 biennial report. These are very relevant to health equity and very much feasible when CHWs and CHW programs are integrated into these initiatives. Now, I'm not going to read these recommendations verbatim, but I urge you do have access to this presentation if you want to refer back to it. Take a look at these and you can piece the pieces together and start connecting the dots, and you can see how CHWs and the qualities and their core competencies are vital to building that community initiative to make a difference in maternal health experiences and outcomes. That is exactly what we intend to do at PUSH. To close out this presentation, we will take a brief look at a couple of the studies that I've listed here of evidence-based programs. Obviously, this is not an exhaustive list. There are various programs out there that have integrated the role of CHWs into their programs. As I've stated throughout this presentation, a key aspect of CHWs is their connection to the community served and or the cause to which they advocate for. This allows community workers to provide a more tailored support system for individuals and families. This first bullet highlights the Community Outreach and Cardiovascular Health Trial, also known as the COACH trial. This program paired nurse practitioners with CHWs and demonstrated a decrease in their per patient cost. This program also reported that the pairing of nurse practitioners along with CHWs improved patients' perceptions of the management of their chronic illness. Another review of 18 studies in diabetes involving the use of CHWs, the reviewers found positive results in behavioral and lifestyle changes, as well as a decrease in the use of emergency departments. The next bullet, a reduction of 35% symptom frequency among adolescents in an asthma control study when participants worked with CHWs. Such positive results. Imagine with the few results that we see here and other programs that are not listed here, imagine what would happen if CHWs were employed as key members of various organizations as well as other care teams. In closing, I simply want to reiterate, maternal mortality is a public health crisis. We cannot turn a blind eye to this. These are the faces of women who are no longer here due to pregnancy-related complications, and these are the families and partners left behind. Children are left without a maternal caregiver. Fathers are forced to fill the role of two parents. Families hurt for generations, and society is weakened as a whole. This is the ripple effect that takes place when women die in childbirth or experience life-threatening pregnancy-related complications. The data speaks for itself, and for so many, it hits home. The need for effective change is long overdue. A community approach to health equity and maternal health is how we can move the needle. Community health workers, with their qualities and core competencies, should be part of the dialogue. They should be key members of your organization with a seat at the table.